Ladies and gentlemen, welcome to the Lake Superior Quality Innovation Network, Navigating the Mental Health Complexities of Progressively Younger Long-Term Care Population webinar. Your host, Kathleen Lavich, will now begin.
Good afternoon. I'm Kathleen Lavich. I'm one of the nurses on the nursing home team at MPRO. And I'd like to welcome you to today's webinar, presented by Lake Superior Quality Innovation Network. The Lake Superior QIN is comprised of three organizations: MPRO in Michigan, Medistar in Wisconsin, and Status Health in Minnesota, to support the Centers for Medicare and Medicaid Services priorities for health care quality improvement in each organization's respective states. We will have time for questions and answers at the end of the webinar, but feel free to enter questions into the chat box. As part of our pre-work, we ask you to complete an antipsychotic medication log for all your long-stay residents taking antipsychotic medications, and provided you a template for that. I hope that that was useful for you. If you don't have such a document in your home, I think this is a good one to use and adapt for your own home. And just looking at the headings on the top columns of this log, I think it could really be useful for you in your discussions and when you review those residents on antipsychotic medication. At this time, I would like to introduce our speaker. Michael Goldsmith is the Regional Coordinator of Mental Health Services in West Michigan for Behavioral Care Solutions. At this time, I would like to turn it over to Michael Goldsmith.
Hello, everyone, and thank you for having me. Today, what we're going to talk about is navigating the mental health complexities of a progressively younger long-term care population. And what we're going to look at really is the change in demographic, what we've seen the past decade or so, identify specific mental health complexities and diagnoses that are popping up, and then varied approaches and interventions to best address these individuals, the quality of life, and the culture as a whole, both in SNF settings and assisted living settings. So what I want to do is look at that, as I mentioned, the change in demographic. Statistically, and I always revert to statistics when I look at this stuff because it's relatively concrete, but we have to remember in the United States, there's over 1 million new nursing homes admissions every year. I think this year, 2017, it was something like 1.34 million new admissions. And when we look at the general population of those admissions, 14 to 22% of the new admissions are non-elderly. And how we define non-elderly is going to be 18 to 64 years old, and 65 or above is going to be elderly, simply because that's what's been identified in varied studies and evidence-based practices. And when we were looking at the assisted living data, even though that's a little bit limited, the numbers jump from 22% to approximately 37% that fall in that spectrum of 18 to 64-year-olds, so a relatively young population. And when we look at severe mental illness, 27.4% are diagnosed with severe mental illness. And how do we define that? We look at how the PASSARs do, OBRA program, which is schizophrenia, bipolar disorder, major depressive, or anxiety. Personality disorders fall in there at times as well. Of those diagnosed, new admissions with schizophrenia or bipolar disorder, 54%, so over half of those individuals fell into that younger range, the 18 to 64 years old. And those who admitted for short-term care, the rehab, for whatever reason, whether it be infections, antibiotic, deconditioning, ortho-based stuff, those with severe mental illness, 45.6% were more likely to transition to your long-term care population compared to their peers. And it's important to note, too, when we're looking at all these statistics, we're still not we're not identifying substance abuse disorders because they're not identified by OBRA as severe mental illness. So if we included substance use disorders and a lot of the personality disorders that slip through the cracks, all these percentages would actually go up quite a bit. And looking at the big picture, just looking at the statistics, over the past 10 years, if you look at that, we're getting this not only younger population, but a population that's presenting as chronically mentally ill. They're much more active psychosis, active major depressive episodes, active manias, compared to our geriatric population that has been more primarily dementia, and these other mental health complexities became residual presences within a person's brain or their body or presentation. Now what I'd like to do is look at the actual culture piece. Why did this happen? Why are we seeing these younger folks come into our skilled nursing facilities? Because it's a significant change for us. It's a big change for us. And of course, anytime we talk about mental health, we revert back to the 1970s and 1980s, the closures of the state hospitals. Those folks had no place to go, so they either ended up homeless or a select few wound up in specialized programs, whether that be group homes, some SNFs themselves, or alternate settings. The next is going to be limited resources, and we hear this all the time, whether it be state budgets, federal, facility, corporation budgets. The lack of funding has resulted community-wise in a lack of support, a lack of programs for individuals with chronic mental illness. So these patients end up with poorly managed mental health complexities. They're unstable. They end up in the emergency rooms or repeat, kind of that circular door piece, repeat presence in the emergency departments or hospitals, resulting in their frustrations. And with that, eventually, either APS, medical staff, attending physicians in the ED, or alternate authorities, police, they begin to seek that safest discharge. And a very safe discharge, unfortunately for us, but they have a point, is long-term care, skilled nursing facilities. An individual is safe. They're behind locked doors, typically. They receive 3 meals, they have a roof over their head, there's medical treatment, there's mental health treatment for these individuals. They're actually managed quite well in skilled nursing facilities. Unfortunately, skilled nursing facilities aren't structured to handle that population. Further, we have in the United States, relatively unhealthy is the best way to put it. So we have a younger population presenting with more complex, higher acuity type medical complexities or etiologies. And what I like to highlight when I'm discussing this is Nancy Miller. She's a professor at the University of Maryland. She did a 10-year study. It was across several states. It wasn't just on the East Coast. It spanned most of the United States that looked at the medical complexities and etiologies in long-term care for patients 31 to 64 years old. So those individuals fit within our spectrum, the 18 to 64-year-olds we're seeing. And what she found was there's 3 primary diagnoses within all these individuals, 3 that kept popping up and statistically held their own throughout the span of the 10 years. And what that was is the diagnosis of diabetes, renal failure, and then a diagnosis of chronic mental illness. And a lot of the times, these were together with a specific person. Rarely does a person have just one. They present with multiples. So we look at that. It further highlights the lack of support, the lack of treatment, and the lack of management of mental health disorders and medical complexities for these individuals, let alone you can go into the whole span of a societal, culture, a sociological piece resulting in us just being unhealthy. Now, before we jump too far into this, what I like to do is I want to look at patient testimonies. I think patient testimony is important. We can learn a lot from our patients. And if we really focus on our patients, what they're presenting with, what the culture is, and this is going to vary from facility to facility. That's just the reality of it. The culture of a facility in my region is going to be different than the culture across the lake there in Wisconsin or otherwise. Sometimes the culture is completely different from where I live to the neighboring city, just demographic-wise. That's the reality of the United States. So we need to really look at what our culture is, and I'm not talking culture of the facility, culture of our community, culture of the people that are presenting in our facilities, and look at that throughout the year because it's going to change. We see that fluctuation quite frequently in long-term care. Sometimes it seems as though it's feast or famine as far as referrals. And when it's a feast, a lot of those referrals are younger and they have mental health complexities. So first, as far as patient testimony, we're going to call her Kathy. That's not her real name. I had 2 of these. Both of these individuals actually helped. They knew the purpose of me wanting some quotes from them, picking their brain beyond me actually treating them. So I'm going to go with Kathy. She's a 57-year-old single white female. She was residing in an assisted living facility when I came in contact with her. She was working as a physician's assistant, a psychiatric physician's assistant, up to 6 months prior to her admission. Interestingly enough, she's an exceptionally intelligent individual, and she remains that way despite some of the cognitive complexities. She presented with a change in mental status, which was first noted approximately 12 months prior to her admission. At that time in the ED, and fortunately, she went to an emergency department that I'm familiar with. I also oversee a clinical crisis team for the Spectrum Health Hospitals in Michigan here. We do all the traumas, mass casualties, all that fun stuff. So I'm familiar with the processes. They immediately hit her with a MoCA, which is called the Montreal Cognitive Assessment. She had a score of 17 out of 30, which indicates a moderate cognitive impairment. Seeing that and seeing her age, and a lot of these doctors knew this individual, they quite quickly got her into for a neuropsychiatric assessment, the 4 to 6 hour assessment. And they did this twice after several emergency department visits or presentations. She was, post this assessment, diagnosed with dementia. Dementia is a very vague term. It's an umbrella term. There's a lot that falls into that. What was found is the patient, even though she hit it quite well, had a 20-plus year history of alcohol abuse. She was a functioning alcoholic. She would work well. She was well respected, promoted within the agency she worked. But in the evenings or whenever she wasn't working, quite typically she was drinking excessively. After I met her, I later diagnosed her with specificity, which we have to do now with the ICD-10, with Wernicke-Korsakoff dementia and major depressive disorder. So basically the alcohol-induced dementia. And in talking to her, she's a very intelligent person, a very capable person. She could likely still run a lot of the medical pieces in the setting that she's living in now. She wouldn't remember what she did the week before, but she had the clinical abilities. Now, some of her statements in talking to her, because her population that was around her was a bit older, just because of the community. She stated, "I'm too young. I don't belong here. I try to develop relationships, but they're too confused to understand me, or we don't have the same interests. It's a different generation, you know." And she hit the nail on the head. It's a different generation. And I'm going to touch on that a little bit down the road here in talking about the intergenerational piece that we're seeing. The next individual patient testimony is Ricky. Ricky is a 21-year-old, single Hispanic male, no children. He resided at the time I found him in a skilled nursing facility. He was there for rehab post a motor vehicle accident. It resulted in right-sided paralysis, which was temporary but took a long time to resolve, multiple fractures and encephalopathies. He was very dependent on staff, but he was a nice young man. He was cognitively intact when I found him, when I assessed him, but looking at notes, it seemed as though he had some clouding after the accident, likely a delirium or minor brain injury, in my opinion. I was referred to him, or he was referred to me for disruptive behaviors. He was non-compliant with some care, some medication. He had verbal outbursts. He was verbally aggressive with specific staff, and staff reported that he was isolating. He was withdrawing into his room. He didn't want to even come out for rehab. He wanted them to come to him. So in talking to Ricky, and I'll hit on him a little bit because he's fascinating, what he says is a lot of them, referring to staff, are as old as my mom, and they treat me like their child. I'm not a child. I'm not a kid. I don't need that. I don't even use that light anymore unless I can't figure it out or my girlfriend's not here to help me. I don't go out until 8 or something. That's when they're all in their rooms. What I found is, in Ricky, he has no mental health history. He has no substance abuse history. Relatively normal kid at that time. What he was doing, and which is indicative we find here in West Michigan for his population, his demographic, I guess, his Hispanic heritage, he worked excessively. He was pulling 12-hour shifts, 18-hour shifts, 7 days a week. What happened was he pulled the double. He was going on something like 18 or 19 hours of work. He was driving home and fell asleep and crashed his car, and ended up in a skilled nursing facility. It was a lack of control is what he was seeking. He wasn't overtly an aggressive person or a behavioral person. He just didn't have control. So behaviors and isolation was the way he maintained control in his life. And the fact that they were saying he isolated and withdrew at first seemed correct until I got to know him a little better and he opened up and his family opened up. And the piece to hit on here, his family, is interesting because the facility struggled with it. They weren't used to him. At any care conference, at any family meeting or patient meeting, there was a mother, there's a father, there's brothers, there's cousins. There was always 10 or 12 people with Ricky. And what I found is, I told him, well, I'm not going to come during the day to visit you. I want to try something. You say you don't go out until after 8. Let me come and meet with you around 9 or 10 if that's okay at night. I came. I used a weekend, came at night. He had friends there. Friends visit him every night. They brought food. Family brought food. He was a very active individual after 8 or 9 p.m. until 1 or 2 a.m. He was very active, very social. It was a fascinating case with some education and some environmental changes at the facility. He did exceptionally well, returned home, and I've recently gotten an update from him, and he's back to work, and he's doing really well. He just has to have some adaptive stuff to the system. Now, what we're going to look at is identifying some of the mental health diagnosis, the specific mental health diagnosis and needs of this demographic, the chronic presentations. Back there. Okay, so what we're going to look at is what has been identified as the severe mental illness. So schizophrenia, schizoaffective, the psychosis unspecified, I'll touch on bipolar disorder, major depressive, and anxiety. Primarily generalized anxiety disorder, but at times you're going to see OCD, OCPD, and adjustment disorders with anxiety, maybe some agoraphobia type things. So let's touch on schizophrenia for a second here. It'll turn, there we go. With schizophrenia, this is usually a big red flag for a lot of facilities when they see this come over on a referral because they don't know what they're going to get. Is this person stable? Are they unstable? The hospital says they're stable, but on admission they're in restraints, which probably means the hospital hit them with 5 or 10 of Haldol, and now they're off restraints because of snow. And they come to you guys, they cross that threshold, and all of a sudden they start livening up and you see the presentations. Now, that's only if a person's unstable, if they're not managed. For any individual who has those diagnoses, if they are stable and well managed, they're less likely to be aggressive, behavioral, and violent than pretty much everybody on this call right now, statistically. So schizophrenia, what we truly look at, the primary criteria is are there delusions, hallucinations, disorganized speech, are they tangential, is there a lack of organization in their speech, disorganized or catatonic behavior, and then the negative symptoms. And negative symptoms, what those are lack of feelings or behaviors that are usually present. They don't have joy. They don't feel emotions in those periods. And then the rest, we have to have each of these: social and occupational dysfunction. The psychosis has to be over 6 months. If it's under, it's a different diagnosis. Schizoaffective and alternate mood disorder has to be ruled out because we do at times with major depressive disorder see psychosis. And then we have to rule out any substance, any presence of a substance or general medical condition that could cause this. And then is there a relationship to a pervasive developmental disability? If there's even mild mental retardation, there's going to be some disorganization. That doesn't mean the person's schizophrenic, which unfortunately we saw a lot in around the 90s, late 90s, diagnosing that way, which it was a sad thing. Now, schizoaffective disorder is basically, it forms the link between psychosis and mood. So what you have is a schizophrenic presentation, but with a major depressive piece or a mania piece, a manic presentation piece. That bumps it into schizoaffective disorder. And then the psychosis unspecified is a very vague term. We see this a lot from the hospitals where they just don't know what the person's presenting with. They diagnose them with psychosis, throw them on an antipsychotic and send them to you, and then it's your responsibility to sort through why is that truly there. Psychosis just doesn't show up in our life. There's always a reason. It often falls on the facility staff, the facility med staff, psych staff to determine why is it there and get the appropriate diagnosis or resolve it. A lot of times it's a delirium that's lingering in there. Now we'll look at the mood disorders, bipolar and major depressive. Bipolar disorder is an interesting one because we used to see it as just a manic depressive piece. Highs, lows, and they fluctuate throughout their whole life. What we're finding is all mental health complexities are on a spectrum of different extremes, different presentations from very functional to not functional at all. But with bipolar disorder, we have to have a major depressive presentation and a manic presentation. So for bipolar 1, we have that cycle that we talked about. Several major depressive episodes, several manic episodes that can be psychotic at those times, disruptive, impulsive. But then there's bipolar 2, and bipolar 2 is often missed. Not diagnosed at all. And what that is, a person only needs to have one major depressive episode in their life and one hypomanic. which is basically the person has one gear, one speed, and they're at that speed for 2 or 3 years. So it goes undiagnosed because it really just looks like a very motivated person, a workaholic type person, somebody who is at the office all the time. They're always moving, they're always going, but their thoughts are logical. They maintain appropriate function in their life, so it's often missed. So bipolar is always interesting. Really need to get an appropriate and a specific diagnosis when we have those folks. And then, of course, the major depressive disorder, which has been around for years and one of the most common diagnoses we'll find. And it's characterized by a pervasive and persistent low mood, accompanied by low self-esteem, a loss of interest, anhedonia, and just pleasure in things that they would typically enjoy. Next, let's look at, that's the thing that's going to go. There you go. Generalized anxiety disorder, we won't hit on this very hard, but it's excessive, uncontrollable, and often irrational worry or fear, apprehension, or very expectations about an event or an activity. Something horrible is going to happen if they go to therapy or if they leave their room, the comforts of their home. Sometimes you'll see a somatic presentation, and this is very important. A person could have the butterflies in the stomach, the GI issues, a racing heart, sweaty palms, feeling sick, or chest pains. And I see far too often individuals with chest pains being sent to the ER for cardiac concerns, different things, when really it's just anxiety. Differentiating that's pretty difficult, and I always encourage folks to err on the side of safety, but we have to be mindful of that history if it's in fact there. All right, now we're going to look at personality disorders very quick. And the reason is I see a lot with this younger population, personality disorder traits. Rarely is it actually diagnosed because there's no evidence-based treatment, true treatment to resolve a personality disorder. So a lot of the times in a referral, we'll see person displays cluster B traits, and that's it in a 40-page referral. So it's often glossed over. The person gets into your door, and this is the individual that runs your staff, puts your staff into tiers, creates triangulation amongst staff. You'll see staff who will not want to work on a specific call, have hesitation to come into work, and sometimes even leave work. I have an individual right now, a facility where they have a patient diagnosed with borderline personality disorder, and they've lost 4 staff in the past 8 months because of this one individual. And they're really struggling with how to navigate this person. And unfortunately, they refuse medications, which is common. And so there's no overt behavioral interactions beyond some basic stuff that I'm going to talk about too. So it's important to remember that a personality disorder is a type of mental disorder in which a person has a rigid or unhealthy pattern of thinking, functioning, and behaving. A lot of it's interpersonal. They struggle within relationships. They're either domineering, overly impulsive in relationships, become attached very quick, and then when a relationship ends, even if it's after a week, their world just ended. So you get a lot of dramatics with it. And they're broken up into 3 groups, cluster A, B, and C. Cluster A and cluster C, if you have to have an individual diagnosed with this in your facility, A and C are the ones that are okay. You're going to be able to navigate those and keep your staff relatively healthy. Cluster B, the dramatic and the erratic, are the ones to be concerned about. And the reason is what we have in there is we have antisocial personality disorder, we have narcissism, narcissistic personality disorder, and we have borderline personality disorder. So within these disorders, we get a lot of behaviors. We get a lot of impulsive reactions. We get a lot of false accusations, calls to the state, and at times self-harm. And I'm going to touch on a little bit of the behaviors we see with that down the road, because I like to lump it all together. When personality disorders, I don't like it broken up. I like to just cover it all at once when we do that. So a little bit down the road, I'm going to cover a big chunk of it. And it's important, kind of backing up before I hit on substance abuse, it's important to use staff input. One of the first things I ever look at to identify if a person is a difficult patient or if they have a personality disorder is staff. And primarily if we have, let's say, 2 very good nurses, they work different shifts but the same hall, rarely get complaints, they always do well with people. If you have one nurse stating that patient's wonderful, I never have an issue, they always work with me, and that individual's counterpart who is good as well stating, I can't work with them, the behavioral, it's frustrating, I'm struggling. If I see 2 of those presentations that are very different in 2 people that it's usually quite positive, that tells me something's going on with the patient. They're triangulating staff somehow, and it needs to be further ferreted out. And look at staff if they're voicing that they feel out of control working with that patient, if they feel manipulated, if they feel inadequate when they leave that room, frustrated, irritated, if they're angry, or if they're scared to go into that room. That tells us something's going on within the patient interaction. Something's going on with that patient, and you need to get appropriate psych clinicians involved and engaged in there. So what we'll see with personality disorders, I'm going to get to substance abuse really quick, but what we see here is we have splitting, which is dividing staff into good or bad with the personality disorders. And what I mean by that is, let's say you have an aide in the room with that person. They're telling that aide, you're wonderful, you're great, you do a wonderful job. That Cena you work with, so-and-so, call him Michael. That Cena Michael you work with, he's an idiot. But as soon as it flips, that new Cena, that Cena Michael walks in, what they say is, you know what, you're wonderful. That person that just left, they're horrible. They don't do a good job. So they start splitting staff into good and bad categories and really creating tension. Primitive idealization I see quite often. That's where they attribute magical powers to previous caregivers, previous doctors. You'll get the responses of, Dr. A, B, and C used to give me my Ativan 1 milligram 6 times a day. Why won't you do that? Because it's excessive and it's probably going to put you out. Is why we won't do it. But we hear that all the time. And they can set the bar as high as they want, and it's hard for us to challenge because we've never heard of those caregivers, those clinicians. We don't know them. Passive-aggressive behaviors. We're familiar with passive-aggressive communication, I'm sure, but with a person with personality disorder, especially borderline, the passive aggression is anger against themselves to manipulate a situation, to manipulate others. So we'll see self-harm, non-compliance, call it eating disorders, but not an actual diagnosed DSM eating disorder. The person that's saying, I'm going on a food strike, a hunger strike. I'm going to stop eating until you give me A, B, and C. And varied other pieces of behavior, manipulative behavior, the suicidal statements. Sometimes suicidal is the go-to, well, I might as well kill myself if you're not going to do that type of statement. We see that a lot. Acting out, which is just inappropriate behaviors, and narcissism, which is they perceive themselves as the all-knowing, the all-powerful, and you can't navigate that. I see staff try to debate this all the time, and I understand it because nurses are wonderful, they're brilliant, they know what they're doing. So when somebody tells them they're wrong, our first reaction is to debate that. But that's a losing battle. You will never win that debate. So I always encourage staff, if they state you're doing something wrong, you apologize, say you're going to do it right, and move forward. You don't get into this emotional debate. And then denial. If they do have a behavior, you confront them, they're going to deny it through and through. Now let's jump to the substance abuse. And how to differentiate the different substances. Is it abuse? Is it dependence? Is it just use? Where should we be concerned? And now substance use is just the individual who uses alcohol or drugs recreationally. Primarily social, not overtly to self-medicate for a mental disorder, pain, or anything like that. It can look as though it's abusive at times, and sometimes it will progress into abuse and progress into dependence. But substance use is just when we go out with family and we have a drink, or we're with friends over the weekend and we have a drink, or something like that. Substance abuse is a person using drugs or alcohol despite the negative consequences in their lives. If they struggle at work, they struggle at school, the relationship with the spouse or children is breaking down. Recurrent use in situations that are hazardous. If they're at work and they operate heavy machinery. Drunk driving. Or just operating under the influence. Substance-related legal problems. Continued substance use despite having persistent and recurrent social negative interactions or social problems. They split up with their spouse. Their children won't talk to them anymore, but they keep using. And then dependence. Dependence is separate. The difference between dependence and abuse is when the body and the brain develop a reliance on the medication. You'll see they develop a tolerance. If they stop, they'll withdraw. So if it's alcoholism, they'll have the DTs. They'll have shakes, seizures. It's actually the most dangerous time for a person is when they quit drinking because of all the negative consequences. They have to take larger amounts for longer durations to get the same feeling that they're seeking. social, occupational, recreational activities suffer, or they're just given up completely. A person may have a beautiful hobby, woodworking or otherwise, that they just love, but they stop doing it. They change their patterns, they change their habits. And then substance use continues despite the exacerbation of physical or mental health conditions. So despite physicians or mental health professionals telling them, if you don't change what you're doing, you could die, they keep drinking. Next, let's look at some of the interventions. Maybe? There we go. Approaches and interventions to best address the quality life piece and that cultural piece I mentioned earlier. So what we need to do when we're analyzing the cultural change that's needed, the quality of life piece, the increased sense of belonging for this younger population, because they don't a lot of times feel as though they belong in a skilled nursing facility environment. And at times they don't. But the fact of the matter is they are there, and we need to deal with it. So we need to adopt an intergenerational mindset, which I mentioned earlier. It's recognizing the differences in interests and needs between that younger population and the older population, and recognizing that the same intergenerational conflicts that are present in the real world, in the community, will exist behind your doors as well, in your facilities. And it can result in strained and negative interactions, the resident-to-resident interactions, the verbal threatening at times, which I've seen frequently. We can address this through offering varied activities that are appropriate for not only age, but developmental presentation. Many evidence-based studies in schools of thought indicate that a person they don't fully mature until their age of approximately 25. For females, it's 23 to 24. For males, it's 24 to 25 years old. They all go through a second maturation stage that usually ends at 24 to 25 years old. So our staff, clinicians, we need to be mindful of that. That person is still brain-wise, hormone-wise, changing. So we need to educate staff, talk to staff, remind them of the kind of life stages, the understanding of life stages, where that person could be at and what they're struggling with. And then developing an environment that encourages residents to grow together, utilizing the strengths of that younger population and utilizing the strengths of that older population. And this can be done through the development of role integration or designation. Give them a purpose. Have them volunteer, aid in teaching residents different skills. That younger population is likely going to be more well-versed in electronic computers, social media, email, the internet. Those individuals are great tools to help some of our older individuals who are just getting into having a computer, having an iPad, following their grandkids on Facebook. They can teach some of those tools. You can have little classes, little courses, or one-on-one interactions. And conversely, some of those older individuals who are, let's say, veterans, or they were mechanics, or they had a specific trade, linking those folks with our younger population that had some of their trades, or were veterans themselves as well. Kind of creating that commonality to build their relationships is greatly important. Now, the next thing is, and I see this all the time, is being mindful of the varied schedules of each resident. By history, we always had meals, breakfast, lunch, and dinner at specific times, snacks were passed at specific times, pretty structured. And structure typically eases things for a lot of folks, but it can be difficult for others. That Ricky, if we go back to him, for example, he didn't really liven up until 8 o'clock at night, and he didn't wind down until 2 or 3 in the morning. And I'm seeing that with a lot of these folks. The schedule is just different. They don't want to eat breakfast at 7 or 8 a.m. because they're barely out of bed. Sometimes they get out of bed at 10. And I'm seeing a lot of facilities not necessarily offset their meals, but having alternatives available for these individuals who want breakfast, let's say, at 10 o'clock, and lunch at 2 p.m., and then dinner at 8 or so at night. And they're developing and structuring systems to accommodate that. And one thing I have seen in some facilities, and I really like it, it's really impressive, is the utilization of a kiosk-type little store. That's the best way to put it, where each resident has a card that has access to their resident funds or account, almost like a debit card, where they could, whenever they're hungry, they can go to this automated kiosk, insert their card, it'll tell them how much money they have. They can scan the little food items or snacks that they want, and it withdraws it from their account. And as long as they have dietary issues and everything like that, it's a good way for them to kind of meet their needs without having to busy our staff running to the kitchen for different things. Now, conversely, on the other side of that, those are expensive. It takes a lot of remodeling to do, but the facilities that I've seen do that, and it's happening more and more, are finding a lot of success. Pretty neat thing. The next thing, one thing that I did when I worked in long-term care, when I was stuck, when I was set at one specific skilled nursing facility, by history I started as a social worker in long-term care, then a director, then an administrator. And when I was at that facility, I was fortunate to be relatively close, or each facility I was in, to be close to colleges and universities or trade centers. So I used them. I used students. I liked it. I went there and talked to the teachers, talked to the students quite frequently for volunteers. Brought in individuals who could help these individuals engage in what they used to know. And this goes for the younger folks and the older as well. So music therapist. I used Western Michigan University, their music therapy program often because the students needed hours, so I used music therapy twice a week. Mechanics or trade schools, I had those individuals just come in and talk to some of these younger folks who used to do that. They can't do it anymore, but it's nice to have kind of a comrade there to vent to talk to reminisce with. So engaging the local colleges, universities, trade schools, really anything that can take these individuals' their minds away from the institutional or the medical complexity, that aspect is very powerful. Engage them with their peers in the community. All right, just a second. I'm waiting for the PowerPoint to catch up. There we go. Maybe. There we are, back to 18. Acknowledge community resources available for the younger populations and more capable residents, the able residents. And what I mean by that is some of those day programs, the Easter Seals in Michigan or the CIR in Calhoun County here in Michigan are great examples where they offer kind of roles, jobs, and task engagement or training for specific things, but they also couple it with having individuals on staff who can assist these folks with mental health treatment, support groups, and recreational engagement. They take them out. The CIR is a great example where I have a young man who goes out, he does his little job training there, and when they're not doing that, they go to different things, ice hockey games, basketball games, they go out to lunch together. It's a community-based, funded, state-funded program, so it doesn't cost this patient a lot, if anything at all, most of the time. If he wants to go to a special event, sometimes he has to buy his own food, but that's about it. And then support groups are huge. I push support groups in as many homes as I can, the Alcoholics Anonymous, Narcotics Anonymous, Al-Anon, medically related support groups like stroke recovery, Parkinson's, dementia, and not just for the patient. Sometimes it's for patients' families as well. Now, there's always a hesitation to have the community come into our facilities, especially if it's for an AA meeting. And I understand that. But in those cases where we have that concern pending our community culture, we help these individuals, we link them to different churches that offer these meetings, hospitals, make sure they're aware of what's in the community, and we help them get there. Now again, when I had my own facility, I ran, unfortunately, I'm not going to say the corporation or the city, but it was called the Community's Halfway House, basically. It was a rough facility. We took a lot of younger individuals. A lot of those individuals are on probation or parole, which created other issues. But I ran AA and NA twice a week, both for the community and for our patients and their families, and they were usually packed. Now that ended when my divisional kind of brought us all into a meeting and had us Google our facility and read what it came labeled as. And the first response was, or the first Google response was a substance treatment program, treatment facility, not a skilled nursing facility. So she asked that pretty quick, but we still engaged the community, and it worked. And it was successful when it was in-house as well. It just wasn't great for PR when they would bring us up on Google or other search engines. The next is community transition programs. If they have Medicaid, the NIFTY program, which is what we call it in Michigan, the Nursing Facility Transition Program, the waiver program, linking folks who have the Medicaid resources can qualify to these programs, help them get to a less restrictive environment, if at all possible. All right. Bear with me, I'm just waiting for the PowerPoint to load again. Or if Kathleen, if you can quickly take control of it and go to the next slide, 19, that would be wonderful.
Is that the one you need, Michael?
Yeah, if you can go to 19, that'd be great. I'm clicking on it, it's just not going.
I think we're on 19. Identifying psychiatric psychological interventions.
Okay, I'll roll with it. I'm still on 18, but I'll run with 19. I'll just keep talking and hopefully the computer catches up.
Okay.
Yep, so we'll identify the psychiatric and psychological interventions, consulting agencies, entities. Who can we get in-house? So we need to be mindful of who we have access to, and this is a little bit more difficult for the rural facilities because the resources aren't really there. We don't have psychiatric practice right around the corner, but we get resourceful. We think outside the box of who we can get in there. So what we want to do is, for the psychology piece and psychiatry, for psychiatry we look at the medical doctor, the DO, psychiatrist, but be mindful that a physician's assistant with a psychiatric certification and a nurse practitioner can also do the same thing, especially the nurse practitioner. They can help with that process. And then from the psychology realm, clinical psychologists, we can use them for both the counseling piece, but you can also use them for capacities and clinical form. And beyond what we find, what we'll find within the community as far as MDs, DOs, PAs, NPs, and LMSWs, let's train our nurses, let's train our aides to have the knowledge of recognizing or at least understanding substance disorders, personality disorders, and the complexities of life transitions, the mental health piece. I always find when we better understand it, we're more able to navigate it without becoming overtly frustrated or angry with a patient or having difficulty with the interactions. We understand why it's there. So within that, we encourage our staff to utilize the biopsychosocial approach when addressing residents. Look at the biological, look at the psychological, and look at the sociological, the whole picture, okay? And it's a contrast from the biomedical model, the disease model that we've used for a long time, and every now and then we dip our toes back into that or fall into those habits, but it's supposed to be more effective. Further, the importance of your interdisciplinary team. I can't stress this enough. You have wonderful folks on your IDT, nursing, rehab department, social work, dietary activities, and the medical staff. Everybody brings a skill to that table, and it's important to recognize and utilize each one of those skill sets to their fullest. You'll have great outcomes. And then think outside the box. Engage families in the process as well. They'll note slight changes. They'll know the history better than we do. So I like engaging families to get that history and have them help us with behavioral patterns or anything they've seen or know. All right, next what we're going to jump to. I know on my computer I'm not on that slide, but maybe we'll get to slide 20, which is discuss the importance of the nonverbal and verbal communication piece. Okay, this is an intervention piece. This is a piece that I'm very passionate about. I teach this at university. I teach it in every facility that I go into or that I provide services to as a free service to them and staff. I'm going to start with the verbal piece. I always encourage staff, use the name of the resident to make sure that you have their attention. Even if you've known that individual for 10 years, use the patient's name every single time and approach them from the front if always possible, and I'm going to talk about that in a minute. Then referring to alternate staff members, use the staff members' names. And I see this far too often, and we've all experienced it, where a patient just sees scrubs. It may be a housekeeper, it may be somebody who works in the kitchen, it may be a nurse, it may be a senior. They see scrubs, and scrubs indicate they can help them. And an example of that is, let's say I'm Athena. A patient approaches me for their pain medications. What I state is, my name is Michael, I'm your Athena. Michelle is your nurse. She's the one to provide your medications today. We help that patient get to Michelle, the nurse. When Michelle engages that patient, she states, my name is Michelle, I'm your nurse, I'm going to get your pain medications today. Every single interaction, what we find is patients become more comfortable with staff, but staff become more comfortable with each other. Their morale kicks up. You'll see the shift to shift get more detailed and more helpful, to be honest. So I always encourage staff to use each other's names too. We like to hear our names. Remember our rate of speech, our tone, our volume. Sometimes we have to slow down a little bit. We have to find that appropriate volume where they can hear us and use a consistent tone. And the next piece is a fun piece I like. It's called the rule of 5. It's when we're dealing with somebody who's a bit irritable, agitated, or even violent. Our statements and phrases should be no more than 5 words, and the words should have approximately 5 or less letters in them. It doesn't have to be exact. It just needs to be short and sweet. And where that's found is, or where that's built into it, why I kind of push it pretty hard, it's called the magical number 7 plus or minus 2. It's an extensive study, an extensive theory that hits on the person's ability, a healthy person's ability to navigate, and that's plus or minus 2. So if we've slept well, we don't have stress in our life, we've had our coffee, we've taken our B12 in the morning, we feel good, we can process 9 types of stimulation. Long-term care is stressful, let's be honest. We all have personal lives too, kids or otherwise, which are stressful. Sometimes we don't sleep well, and when we do sleep, if you work in long-term care long enough, you start hearing alarms, you start hearing those bells and whistles in your dreams. In those moments, even as healthy as we are, we can typically process 5 types of stimulation in an environment before we neglect something. So to put that in kind of in perspective, say you have a patient who is agitated. They're demented, so we take that 5, we cut it in half, 2.5 types of stimulation. There's patients around them. There's a group going on. There's the television turned on. There's always a patient yelling in these moments, just by bad luck. And a nurse approaches the person, 2 Cenas. There's always a housekeeper that has a great relationship with this individual. They approach. So before we even open our mouths, we've well exceeded the stimulation that patient can handle. We've pushed a negative interaction. If that person became violent, it would be no surprise. We chose for that to happen. So what we need to do is pause the group, turn off the TV. If we can, move the individual who is yelling, or at least engage them so a little bit more quiet, and one staff member approaches, one staff member talks. We want to minimize the stimulation that person's brain has to handle. And what you'll find is that actually works quite well. With patients, with our children, within life in general, it works quite well. Now, again, with the verbal communication, let's see if we're going to do it.
Michael, we have to pull the time now, so if you just want to tell us when to advance, we can do that for you. Looks like WebEx is having some issues.
Yeah, it looks like it is. So let's just hop back to, if we can jump to 21, that'd be perfect.
Done.
All right, and what does that slide look like for you guys? I'm waiting for it on my end.
Communication and residents that present with traits of personality disorders.
Okay, and we'll jump back into that a little bit. Even though I touched on it, the basic was verbal communication with an individual who has, perfect, I like it, a personality disorder or displays the traits. We want to, for one, recognize the practice of working through, which is for our staff. We want to encourage our staff to recognize our own negative emotions and work through those. Accept them as normal. The reality is we're going to have patients, we're going to have individuals that we struggle with, that we find that kind of annoy us, that ruffle our feathers, that leave us frustrated, that we may not like. But if we recognize that and we deal with our own stuff, we can still be effective and efficient in treating those patients. So I always encourage staff. You know, when I worked in long-term care, when I had just that one facility, my door was always open. I'd rather have a staff member vent, yell, or curse in my office than have them do it in a hall to a colleague, do it with at a nurse's station where patients could hear it, a family member could hear it. I knew on my end they would never offend me, and I'd rather have it happen behind my closed door than out in the hall, because that's negative. Counter projection, we just have to be mindful of when we are frustrated that we don't direct that towards the patient. Sometimes we need patients or our staff to take time out, which is actually a very healthy thing to do within a negative interaction. If that patient is cursing, if they're derogatory, if they're really degrading that person, they're non-compliant, it's okay for that staff, as long as the patient's safe, to break off the interaction and say, you know what, I'm going to take a break for 5 minutes away from you. I'm going to come back in 5 minutes and ask to help you because I would really like to help you. And then we come back in 5 minutes. We have to be consistent and offer to help them again. And then limit setting, which is basically, it goes with taking the time out. Limit setting is establishing boundaries and expectations and maintaining those, giving the individual an opportunity to choose to work with us in a healthy manner. And if not, we document it per our facility, the corporation protocol. And if they want to refuse care, they can refuse care. We just have to take the steps moving forward, whether it's documentation, if it's self-harming, then we have to get psych involved, we have to consider placements, everything like that. We want to cover our bases. But staff should not be beat up every day by these individuals. And that's kind of the front line of that, is we don't want staff to be beat up, burnt out, and quitting. But the back end of that, individuals with personality disorders developed this pattern of behavior. Over 40 or 50 years, they've perfected it. And it is, in fact, a pattern. So by breaking it off, taking time out, we're breaking that pattern. It creates a little bit of anxiety, but anxiety creates or elicits change in the brain. So we're actually, from a behavioral piece, helping that individual in the long run create healthier interactions, abilities, and coping skills. Now let's jump to the nonverbal, which will be slide 22.
You got it?
You're on it? Perfect. Now, the nonverbal is a big piece to me. Nonverbal communication is 70% of every single interaction, not just for patients, but for us as well. Our brain's working 1 million miles a minute as soon as we see a person. We watch their gait, we watch their body posture, we watch their face. We watch truly everything about a person before they say hello to us and make a determination in our brain of is this person safe. So I always encourage staff, approach in a slow, calm manner. Approach from the front, if at all possible. And strangely, this is a United States thing. Allow the patient to see our hands. It's kind of a U.S. thing, Australian, English, and Scottish thing. Our brains, for whatever reason, if we cannot see somebody's hands, we have a minor dopamine shift, and it creates a mistrust of that person prior to the interaction even starting, which seems easy at its base, but the reality is in long-term care, nurses are writing in Mars and TARS. They're looking for meds in the med cart. They're shuffling papers. They're working behind a desk. Or they're looking for a pen in their pocket. Pens are hot commodities. They always disappear. Everybody's always looking for a pen. So we have to be mindful of just let the patient see our hands briefly. That'll help with the interaction, as simple as that is. Again, never approach from the side or the back. And the next is going to be what it's called the 10, 5, and 3 rule. I developed this rule with Dr. Liz Foley in 2001 or 2 when we were working in the Department of Corrections. If you remember, 2002 was after 9/11, 2001, and at that time, Homeland Security and the Corrections funds in Michigan merged. Of course, vast majority of money went to Homeland Security. Corrections we cut, so we had less guards. We had to develop systems to help with interactions with in the prisons. But I found this carried over into long-term care quite well. When we have what it stands for is 10 feet, 5 feet, and 3 feet. When we have an agitated patient, an aggressive patient, a younger patient who's threatening perhaps, threatening violence perhaps, their comfort zone with us is 10 feet. Their bubble is 10 feet. That's where one person engages them. They talk to them. They validate that person until the person, let's say, the tone goes down, the volume of their yelling goes down. Maybe they're no longer threatening, but they're a bit irritable. The person can move to about 5 feet. And they keep talking to that person. They keep providing supportive dialogue. They keep providing validation and using that rule of 5 until the person's actually having a conversation with us. When they're talking to us, we can move to about 3 feet. That's a very intimate interaction. 3 feet is close. But what we want to remember is at 3 feet, that's where our interventions are going to be most successful. Whether it's introducing a medication, engaging that patient to move to, let's say, their room or a less stimulating environment, or introducing a stimulation type interaction, something tactile, something for them to play with, something like that. Now let's bump to the slide 23, I believe we're on. If I could help with that.
Yep.
All right, are you guys there?
Yep.
Awesome. And basically what we're looking at here is the different tools to utilize within our facilities. And there's a lot of them. So we're not going to cover a lot of them just for the sake of brevity, sake of time. But the one that I do want to hit on, and I see that most facilities don't have but need to use quite often, at least in West Michigan, is individuals coming from the hospital who are still having DT. So it's the CIWA-AR. It's the Clinical Institute of Withdrawal Assessment for Alcohol. It looks at nausea and vomiting, tremors, paroxysmal sweats, anxiety, agitation, tactile stuff, auditory disturbances. It basically monitors that person through the process of the DTs. Okay? And that'll help when state reviews and ask, what are you doing for that patient? They obviously came in with withdrawal symptoms. Did you monitor? What were the outcomes? It helps you with that. The next one, we're looking at substance abuse. We have the CAGE questionnaire. I like the CAGE, and it's the one I use out of that group most frequently because it's short and simple. The 4 letters are the 4 questions we ask. The C stands for cut back. We ask the patient, do you ever feel you need to cut back? The A stands for annoying. We ask if do you ever find somebody or a person or get annoyed when somebody tells you or highlights your substance issues. They highlight concerns. The G is guilty. Do you ever feel guilty for your use? And then the E is an eye-opener. We ask a patient, do you ever need an eye-opener when you wake up to kind of get you going for the day? You have to have that substance in your body for the day. It works well. It's quick. A social worker, a nurse, anybody can administer it, and it creates a pattern. It gives us a picture of what we're working with and if we need to integrate more. The next is going to be for the substance abuse piece, the DAS-20. It's just a 20-question drug screening tool. They have a DAS 10, 20, and 30. I like to fall right in the middle. I think it's usable, but it's not too long and it's not too short. So the DAS 20 is a good tool. And I believe on the next slides what you're going to have is some different tools for mood. You're, of course, familiar with the PHQ-9. I listed the 3 tools, the Columbia Suicide Scale, the SAFE-T, and the SBQR, I believe it is on there. I use those 3 tools with every single suicide assessment. It seems I'm doing that more and more. It gives you a nice picture. It paints a picture within your documentation, and it identifies specific risk. Is the person low risk of self-harm, mild, or high? And really what this does for us, it takes away some of the guesswork of does this person have to go out? Are they a risk? And anybody that falls within the high risk, the recommendation is they've got to go. They've got to go either to the ED for further treatment or they need inpatient psych treatment. So it's a nice tool. It paints a picture within your documentation. It gives you something to back up your clinical opinion, your nurse's clinical opinion, because sometimes it is a nurse at 2 a.m. that's going to do this in your facility. They're very easy to use. They're nice tools. And the next one I'm just going to touch on, I would like folks to look at just the psychotic disorders. It'll be on slide 24, the next slide. And there's no real tool to identify a psychotic disorder. But there are tools to monitor. And what we want to look at is, are there gaps in compliance? Is there psychosis present? It kind of lays out a picture of what we're working with. Because if there's gaps, we're going to have psychosis. A lot of these are going to be self-report, so the patient can fill them out and return to you later. So I like that because it saves staff a lot of time. Sometimes social worker activities will have to sit with them and help them with it. But it paints a picture of what that person's dealing with psychosis-wise. And if there's anything we need to do more, if we need to develop a program that might encourage compliance a little bit more, develop behavior contracts, it gives us an idea of just what we might need to do or if we need to do more to maintain that person's stability. Because even with schizophrenia, the reality is if that person is well managed, they may be a little bit odd or weird, but they can be extremely functional. I have 2, I own a separate practice as well. I have 2 patients who are schizophrenic, have schizophrenia diagnosis, but they're very functional. They hold full-time jobs. They're both college graduates. They're very functional, and they just recognize at times that they need treatment. They're going downhill. They're going south, and they know when to seek it so that their life doesn't become so disruptive. Because the reality is with psychosis, and this is something I'll throw in here before I open it up with questions, in the state the state of Michigan, I'm assuming other states too, they hate this idea, but the fact of the matter is evidence-based practice has shown this over and over again. If a person is starting to become psychosis, an immediate initiation of a low-dose antipsychotic is the best way to mediate that psychotic presentation. And it's temporary that way. We use the antipsychotic briefly, we resolve it, and then what we introduce we can usually take off and the person can be on their normal meds again and be stable. But what we find is there's a lot of hemming and hawing about an antipsychotic being used, so it takes 3 or 4 days to get psych in there, maybe more. We talk about it within the IDT. We talk about it with med staff. And then by the time we actually have psych in there, they write their recommendations and it goes back to med staff. We're a week plus, sometimes 2 weeks out before the medication started, and we have a full psychotic presentation. We're no longer in the phase of we're trying to just squash it and get rid of it and we can get rid of the med in 2 weeks. We're probably going to have that person on an antipsychotic for 6+ months to mediate that. So the introduction up front and as quick as possible is the best way to mediate it. And a quick thing about medications, going back to suicide, I always like to impart this on people. The one thing that's been found to be most effective in mediating an acutely psychotic presentation is the introduction of an anti-anxiety medication, Xanax or Ativan. As soon as you relieve the anxiety, in 90% of the cases, the acutely suicidal thoughts disappear. You just have a depressed person, and we can deal with that. And they no longer need inpatient, which is disruptive for a person. Now, I'm at the tail end. I want to open it up. I know we went over a little bit. I want to open it up for questions.
Okay, ladies and gentlemen, at this time, if you have a question, please press the number 1 key on your telephone keypad. Again, if you have a question, please press the number 1 key. Our first question will be coming from Emily Myers. Please go ahead. Emily, your line is live. Please go ahead with your question. Our next question will be coming from Pat Dowd. Please go ahead with your question. Hello, Pat. Your line is open. Did you have a question? No? Okay.
Thank you, Michael. I want to thank everyone for joining us today for this webinar. And we did run over. I mentioned that we have additional time for questions, but you can always put them in the chat and we can collect them and touch base with Michael for answers to your questions. The recording will be available on our Lake Superior QIN YouTube channel within the next week. And at this time, let's pull up the evaluation questions. Please take a moment to let us know how we did by filling these out. Thank you. And again, Michael, thank you so much. That was a wonderful presentation. I know I learned a lot today. Thank you.
Yep, thank you guys. I really appreciate it. I enjoyed it.
Thank you, ladies and gentlemen, for joining. You may all disconnect at this time, and have a great afternoon.